Okay, so if we increase the flow back to the heart, that's going to put more tension on those muscles that are in the ventricles. If we put more tension on those cells of the muscle, we're going to increase the contraction. And by increasing the contraction, we'll increase cardiac output, meaning we're matching the return to the heart, which would increase at the time of exercise. So that's one of the ways that we can actually match this heartbeat and the stroke volume. This is, or this I guess I should say, was discovered and given a law. It's called the Frank-Starling law, meaning stroke volume is proportional to that end diastolic volume. Basically, the ventricles will eject as much blood as they receive. So if you send more blood back to the heart, the more they will eject out. They will actually stretch. The muscles of the heart, if we increase that blood flow return, the muscles of the ventricles can actually stretch to match that blood flow. Matching that blood flow, increasing the contraction, would increase the amount of blood getting ejected out. So if we're at a time of exercise, thank you, at a time of exercise, if we have that increased blood flow, and then we're getting that increased return to the heart, if we continue that exercise, it's got a beat, more beats per minute. It's getting more of a return. The heart stretches, the heart beats, and it's a law for it. Basically saying the heart matches what it receives. It's because of this length-tension relationship. Do you guys remember that in the skeletal muscle? In the skeletal muscle, what was one thing that was important to do for the skeletal muscle before you started an exercise? You needed to stretch those muscles. It's one of the reasons it's important, okay? Like the people who are going to run and everything, that you see them doing this number, and you see them doing this number, and you see them doing that number. What are they doing to it, to those muscles? Okay, they're stretching them out, they're lengthening them. They are, it's going to be less tension. We're making them have the ability to contract, okay, at a harder rate for the exercise. But what is one major thing that we're doing to that skeletal muscle as we warm it up? Do what? We're increasing our blood flow. So if we're increasing that blood flow, am I not increasing the return to my heart? Which is now going to need to stretch to match it. And then it needs to do that the more I warm up and actually do the exercise. Then, once you're done with an exercise, what kind of happens to the muscles? They're sore. They might be a little more tension to them. But eventually, rather than being more stretched out, they're doing this number. Okay? So what do you think is going to happen to the heart? It's going to not be as stretched out. And therefore, force of contraction, not as strong. And what am I going to do to the blood flow? Decrease it. Does that make sense? The Frank Starling law.
So when you're exercising the heart,
Yeah. It will actually stretch out just like other muscles of the body to match the demands placed on it. Now, is that always a good thing? No. That's where the heart, it's usually due to like maybe a genetic disorder or some other diseases or something like that, and it causes that muscle to stretch out over a chronic time period. And because it's stretched out over a chronic time period, it never had the ability to contract back, and it never will. And that becomes an enlarged heart. That means the heart's not pumping correctly anymore, and the amount of blood flow is no longer correct. And that usually can kill a person, having the enlarged heart. So the preload, the contractility, contraction, okay, that second variable. What is the strength of that contraction? There are positive agents that can increase the contraction. We already looked at the calcium. Catecholamines, the calcium. Glucagon, sugar. Digitalis. Have you ever heard of that one? Digoxin? Mm-hmm. The medication. Okay? Sometimes people need help with the contraction of the heart. Kind of look at that sugar one day. Think about my grandchildren. Some negative agents that affect the contraction, the hypocalcemia, the hyperpotassium, and then that little vagus nerve with the parasympathetic division. If we affect the contraction of the heart, this is one of the 3 factors for the stroke volume. If it's one of the 3 factors for the stroke volume, and we affect the contraction, have we not affected stroke volume? There you go. So preload, contraction, afterload. All the forces that can oppose ejection of blood from the ventricle. Biggest part, the blood pressure in the aorta and the pulmonary trunk. Why? Because they affect the semilunar valves. Because semilunar valves go into the aorta and the pulmonary trunk. Do you know anybody who has this problem. We know it more commonly as what? High blood pressure. Blood pressure under normal conditions. Our body is controlling this with negative feedback. It's controlling it with the kidneys. Okay? Under normal conditions, blood pressure is constantly fluctuating, but these systems work together to keep our blood pressure at the norm. Roughly that 120 over 80. 110 over 70 is what they like to see. Okay? Keeping that blood pressure at a norm. However, we tend to have situations where people are in chronic hypertension. If they're in chronic hypertension, what tends to happen to the heartbeat? It increases. So now, if we increase the heart rate, all right, that's one of our factors for this overall cardiac output. If we're increasing that heartbeat, we're sending out more blood, meaning we're going to return more blood, which is going to increase our preload, which is going to affect the contraction. Now, this hypertension is a major factor in afterload. Basically, this ventricular ejection. In chronic hypertension, if the afterload is affected, we are looking at the actual effect to structure of that heart. One of the things that can happen, too much fluid, stretching out those muscles, making it enlarge under a chronic time frame, and therefore leading to something like the enlarged heart. Have you ever known someone that's like, no matter what, they can't get their blood pressure under control? Might be on 2 or 3 medications, still going to the doctors, blah, blah, blah. These are the people who are usually going to end up with some other types of problems.
So I know can stimulate blood pressure medication.
They continue to take it.
Yeah. So how does that how does the stroke leave those long-term effects?
Now, when we talk about a stroke, usually what has happened, there's been a stoppage of blood to an area of the brain. That's usually based on a blood clot, and then they have to usually do something to try to dissolve that clot. But a lot of people who have high blood pressure, they're at a higher risk for that to take place. And that's because the pressure at which the blood is leaving the heart, and remember, when we have the aorta, there's branching directly to the brain. And if we're under high pressure, that's a high pressure of blood flow to the brain also. So they need to make sure they keep that blood pressure down so that it's not the pressure in the brain.
Okay, so it's just a higher risk, it's not that you're under pressure.
It's a higher risk of having the stroke. And see, you got to remember, having that, I mean, that blood flow leaving the heart, hitting the kidneys, okay, and then you think about a direct path to the brain. That's why a lot of people who have high blood pressure, when the blood pressure's up, they hear it in their ears and they feel it in their head because it's direct blood flow under that high pressure going to those tissues. And that's not good. That's not good. anything that affects artery circulation can affect afterload. Lung diseases. Lung diseases restrict the circulation in the lungs. Now that's our pulmonary circuit. How is that going to affect systemic? All right, number one, my blood flow to the pulmonary circuit, it's not picking up the oxygen it needs, might not be dropping off the CO2 it needs to get rid of. What is that going to in turn do to my systemic circuit? So we're not going to get what's needed to the tissues. If I'm not getting what's needed to the tissues, cells can't get what they need. Core pulmonale, something that will be probably something you see once you get into your programs. The right ventricle is failing. That means blood flow to that pulmonary circuit, which is to the lungs. Something is going wrong with that circuit. Found very likely in emphysema, chronic bronchitis, and black lung diseases. All of those are diseases that affect the respiratory system. Not going to spend a lot of time on this one because I've already mentioned the exercise and cardiac output, because I keep mentioning that we match it, okay? That based upon